But let's kick it off, and let's start with you, Swapna, since you were the first one to kick us off. We've got a couple of notes that came through. One of the questions is, how do you find adult centers of excellence that understand SBS and your needs as an adult patient?
Wow, a hard question right out of the gate. It's a great question and one that we can improve on a lot. So I would advise other patients, one, the Lift Echo information on the Oley website, props to Dr. Iyer and others, has an advisory panel, and they represent different institutions in the country. In those institutions, I can say they're well respected, and those physicians and clinicians are represented even here today. And then I would, if you're part of a home infusion company, wherever you are connected with clinicians, to ask. I was referred to the team that I have now. It took a lot of turns and tries, but got to where I am today, which is a multidisciplinary adult care team out of state, after my dietitian helped refer me there and recommended that I change from a local physician who is not a multidisciplinary care center. So to use the network that you have, and hopefully we, as a field, can improve that list in some form or fashion.
Awesome, thank you, Swapna. There are several questions about hydration and different formulas. So I'm gonna direct this broadly to the group. Maria, Dr. Michalek, anybody who feels like they have an opinion in this, by all means jump in. So here it goes. Is almond milk better tolerated than soy milk? I used to be ill from an occasional sugar-free soy latte and switched to almond milk, and I feel better.
I guess I should jump in. I think it's great that she feels better. I'm not sure. I would think the sugar is probably about the same between the two. So I think going with what is working makes a lot of sense. And a lot of people have turned to almond milk as an alternative to regular milk and soy as well.
I'd just like to add, though, that the protein content is quite different. So if you're using it as a source of protein, you're not getting very much protein from the almond milk relative to soy milk, at least from my experience. You can correct me, Maria, if I'm wrong.
And one of the products we've used for where we've had to use, I agree with you about the protein in general, but one product we've used for patients who want to take almond milk is something called 3 Trees. I'm not promoting any company. I don't own stock, but it has a higher protein content than conventional almond milk, and it is only almond.
And I see Dr. Kimberg has put in the chat that they recommend oat milk. So that's also an option for people. She says it has more protein.
And that's why I actually like a newer product to the market, Fairlife, which is, again, I don't have any investment in the company either, but it's really nice, no lactose milk with higher protein and half the sugar of regular milk.
Yeah, it's a good product.
Switching gears a little bit, Dr. Mercer, we received a question around the fact that water is absorbed and reabsorbed in the colon in all people. Why not hypotonic fluid? Well, why would hypotonic fluid be okay in SBS patients with an intact colon? And if not, why not?
Sorry, did they address that question to me? I'm happy to address it.
Yes, that came in when you were speaking.
Okay, yeah, no.
But we can open it up to the panel too that has any thoughts.
So I think what the question was saying is, why are hypotonic solutions okay when we have colon incontinuity, or why are they better tolerated? You know, the simple explanation for everyone is when we're fundamentally salt water, aren't we? And so if we drink water, plain old water, the water gets into our body And then the way our body handles it is it turns it into salt water, and then it absorbs back the salt in the water. Now, if you have all of your intestine, you got tons of time to do that. So it's no big deal. You can fire the salt into it, you can absorb it back, you can absorb it in your colon, and that's what we do if we have all of our bowel. But if we don't have all of our bowel, the problem is we do the first part of that, we dump the salt into it, and it's already on its way out the other end. And so taking a lot of hypotonic solutions will tend sometimes to just drive our output and also lead to just ongoing salt losses. And so we try to use isotonic or even ever so slightly hypertonic solutions. If you have your colon, if you have lots of colon, because if you have a little bit of colon, it's not way different. But if you have plenty of colon, then you have different mechanisms that allow you to absorb that water back a little bit more efficiently. And so while you still may actually benefit from, I mean, in general, you're going to do a little bit better if you don't have all your fluids be hypotonic or sugar containing solutions, but you'll do a little bit better. It isn't quite as big a problem, especially if you have the full length of your colon. Normally, most people can get away with more indiscretions the more large bowel they have.
If I may add to what David said, I get this question from patients often, and I actually tell them, even for healthy adult human beings, plain water is actually not a good solution. We get away with it because there's so much redundancy in our bowel. Yeah. And as you lose bowel, it becomes more critical that you try to maintain the chemistry in a tighter window.
Now, in fairness to people, sometimes, I mean, not everyone wants to have a salt-containing solution all the time. Sometimes there's questions of palatability. So at least we would say, look, try not to drink a ton of sodas each day. We all have to have a cheat here and there. So if you have to, that's okay. If you can, if you like your soda and you're going to have one a day, put a pinch of salt in it. After you do a pinch of salt, you won't notice it. And then you can put a couple pinches of salt. And the other thing is, if you're going to have water, then maybe try to have something salty at the same time. So at least it kind of turns into salt water on the inside. So maybe you got little baggies of pretzels in your car and all over the place, and you have little salty snacks that you like, and have a salty snack at the same time that you drink that water. And at least you're going to be a little bit better off than if you just chug straight water.
Yep. All right, thank you. The next question is for you, Swapna. Here's the question. You've accomplished a lot, both personally and professionally, there's no question. For those of us who are also trying to prove that chronic illness can mean having a fruitful professional career, not just a job, can you describe one of the hardest things you've encountered in your professional life and what advice you can give on this experience?
Yeah, I think there's two things. One, so of course, there's still fear of the unknown. When am I going to get hospitalized? When will I be debilitated of function, sepsis, or whatever could happen? I always say sometimes I'm a bomb waiting to go off with everything that is inside my body. And so, but because of that, I think I push a lot in the times I do have health. And so I can sometimes appear like I do a lot. And that is a lesson where you can't do everything. And that's something I'm learning, where what can you delegate? What is something that you do need to focus on or put away to the side and focus on later, and really manage the time. And then the other thing is, I think, really going back to what we can control, because there's so much in our health and our journey in medicine that we cannot control. It comes back to us in our work, where it's very hard for me to delegate and create a team to really think about how to create these projects that are sustainable beyond me. And so those are two things that are really hard, and still trying to learn as a professional to create a long-lasting career.
A question that came, what's that?
We can hear you now. For a second, we couldn't hear you.
Okay, great. A question came in during Dr. Iyer's presentation, but again, anyone can feel free to chime in. What are the long-term complications, or what complications due to reduce acid production? One of these needs to be used. Does one type have a lower potential of affecting bone health regarding calcium in the bones?
It's a good question. There is some evidence that long-term use of acid suppression can accelerate bone loss of bone mineral density. And there is a second concern that we depend on a certain level of acid in the stomach to maintain the milieu, maintain the environment inside the bowel of the various organisms. So there is some evidence that prolonged acid suppression may actually increase the risk of bacterial overgrowth in the intestine, may increase the risk of even fungal overgrowth. So particularly, I will say that we tend to use acid suppression longer perhaps than we should, but certainly in the patients having frequent infections, or if there is evidence of bacterial or fungal overgrowth, we would consider stopping the acid suppression at least for a short period. I am actually not aware that any single acid suppressive agent has a greater or lower risk of affecting bone mineral density, Anne, or anybody else?
No, I agree with you. I think it's just the fact that there's no acids. It doesn't matter how you get there. That's what affects the calcium. However, I think, taking a little bit more calcium in your diet is going to be beneficial. And when you use a supplement for calcium, you should use calcium citrate, because that does not require the stomach acid. So supplementing your calcium using calcium citrate, you can overcome the absorption issues that are created by stomach acid secretion.
I will also say that it is clear now that we've been wrongly advised all our lives. Every one of us, panelists included, is vitamin D deficient. So it probably is a good idea for every one of us to be taking a vitamin D, including patients, family members, neighbor's uncle. Everybody should be taking a vitamin D. Don't just say I went out in the sun, that's not enough. And we see some, and I'm sure David will attest to this, we've seen some kids. We've recently I operated on a patient from Boston 3-4 weeks ago. He had unexplained shoulder pain after surgery, and we thought, is it possible something happened during surgery? Arm was stretched. And when we investigated, he had extensive osteoporosis and a previously unsuspected fracture of his radial head. He, of course, had a double whammy. He had kidney dysfunction and TPN long-term. So this really, I think we're not doing enough to safeguard bone health in our TPN patients, partly because maybe we're not sure of what is the right approach.
And if I could just add, I was just going to add, if I could, to Dr. Michalek's point about the calcium, and to what you're saying, Dr. Iyer. There's just really no downside to taking the calcium, because there's always a question as to whether, especially for those with a colon, should they be limiting oxalates in the diet? Instead of being more limiting with the diet, I take the approach of adding the calcium to bind the oxalates, instead of, being worried about where to cut out oxalates in foods.
Maria, that's very clever. So just in the last 10 days, I've heard 2 clever women give good practical advice on this course. So last week I heard from Carol Semrad at University of Chicago, gave a talk on echo as it was. And among other things, she said for patients who have colon, it's a good idea to check oxalate in the urine on a screening basis. And as soon as it starts to go up, introduce the calcium. And now Maria is saying, what the hell, you're taking so much, take a calcium also. And it'll prevent your oxalate stones. I think it's a good idea.
Be good for your bones. So you're getting 2 benefits.
And to the point about vitamin D, in patients with short bowel, you may find that you need to take a lot of vitamin D. Sometimes is meant 5 to 10 times more than somebody without. So your vitamin D level ought to be monitored pretty regularly, and your dose upped and upped and upped until we can get it normal.
Yeah, we use industrial strength doses.
Yeah.
David, there's a question.
We utilize the sublingual route too when we're not getting where we need to go with the vitamin D as well.
What do you use sublingually?
The vitamin D, liquid vitamin D.
David, there's a question in the chat that I don't know if you've already answered, but I'm intrigued to hear your opinion. Your thoughts about spiral intestinal lengthening and tapering, SILT?
Yeah. Hey, I was going to take a moment. You know, there was a whole bunch of questions addressed to me about different surgery things. And I must say, I intentionally didn't answer them because I thought I wasn't supposed to. And I was waiting to come up. I promise everybody, if they don't come up in the context of the discussion, I'll try and address them all, or, you know, send like contact the organizers and I'll respond by email. So I will get to them all, but I didn't realize I was supposed to, so I didn't.
Now
so the SILT for,
I'm also not supposed to, but I'm breaking the rules.
So a SILT, everyone, is a type of procedure where you can modify the bowel by, the way I think about it is, does everyone know like Pillsbury dough? And if you ever have had Pillsbury dough where you take the outer wrapper of the Pillsbury dough off and then you pop the little thing and it goes, and the dough kind of puffs out. Well, if you took that container and then you twisted it closed again, it would sort of lengthen out a little bit longer. And that's a SILT procedure. That takes that puffy stuff and rotates it and makes it. So that's what you do in a SILT. It's conceptually kind of a cool operation. I must say I haven't used it, not because I have a problem with it. I suppose it hasn't necessarily come up for me yet, Kishore, and for whoever asked the question from the audience. There's been times that I must say, when you're doing revisional surgeries, and if you've done this where somebody's been operated on a bunch of times, sometimes you can be pretty limited in what you can do, especially if the previous surgeons didn't, you know, I'll try to be politic in it, but if they just didn't quite know what they were doing and stuff gets kind of all off axis and weird and wobbly, it could be really hard to fix surgically. And there is times when I thought, God, I wonder if I should do a SILT here. You know, maybe that would be the right thing. So I haven't done it as a matter of course. That's not to disparage the procedure. It could be awesome. I think someone in the question had answered, you could do it when the bowel is less dilated. Yeah, I suppose, I guess for me, if the bowel is less dilated, I'm not sure it needs anything then, but it's not to say that you couldn't do it. So Kishore, maybe you've done it and you can say if you've done
David,
it.
I'm actually quite pleased to hear you say this because I've also felt the same thing. It looks like a clever operation and maybe that's why you don't quite have the same amount of gray hair that I do, but we both have gray hair. Just because something is cool and interesting is not reason enough to do it. It's a clever operation. It's a clever concept. I'm not sure where exactly I would do it. And it just seems to me, I struggle to understand how the juice would be worth the squeeze. That's a lot of squeeze there.
And that's why I've not done it also.
Yeah, and I don't do well with Pillsbury dough also, so.
Okay, thank you.
It's a good visual.
Graphic.
I'm gonna.
It's Joan and the police, the time, please. We have time for one more question. We're running right to the absolute deadline.
But Joan, before we get into the last question, I do want to tell everyone, if you do have follow-up questions, by all means, you can send them to the Oley staff. They'll ask the panelists using the email address oleyfoundation@gmail.com.
Absolutely.
All right. Okay. The last question will be for Dr. Michalek, but I think others may have opinions as well. Someone asked, I only have 1.5 feet of bowel, Crohn's, ileostomy, 2 bags of fistulas, and a G-tube. What should my strategy be for retaining fluids?
Whoa. Boy, the strategies to absorb are going to be the same, but you've got a lot of places where you're losing fluid. So I'm not quite sure that you're going to be able to accomplish significant, improvement in your fluids. And so it really comes down to your team making sure that we're replacing what needs to be replaced. And making sure that you stay hydrated. And the best thing to do is keep an eye on your urine output if your kidneys are normal, because if your urine output is low, that means that you're probably not getting enough to replace what you're losing. And you can go into trying to measure, but you've got a lot of things that might need measuring, and it might be, pretty difficult to do. But monitoring the urine would probably be the, first step in terms of seeing where you're at. but it's going to be, you've got a lot of places where you're losing. So even if you're absorbing better in between, I think you're going to end up in a negative state. So the replacement fluid that you're getting is going to be fundamental to maintaining your hydration and protecting your kidneys.
I would jump in just real quick because I was going to address this by typing, but I'll just do it because it's quicker this way. I must say that I think that it's worth seeing a specialized center to find out about getting your anatomy corrected. If for nothing else, if you have multiple fistulas in the front, and that's difficult on your skin and on your quality of life, I can tell you, you can take a patient and you can hook their proximal, I don't know how much large intestine, but you can hook somebody's duodenum or their proximal jejunum to their colon, and they'll have a really good quality of life. And so I would encourage you to avail yourself of pursuing that. Just because you've been told by someone that it can't be done doesn't mean it can't be done. And somebody else could conclude, or you could conclude that's not the path you want to go, and that's fine. But I wouldn't just sit and say, no, this is how it is, and this is what I have to do, because I don't agree with